Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Adelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board certified pediatrician, and international board certified lactation consultant. I care for breastfeeding diets in private practice in the outpatient setting.
Hey, Lena, how's it going?
Hi, Anne. Things are going well. How are you doing?
Good, good. Well, let's start off the new year with some interesting articles for our podcast.
Sure thing. I'll go first. I picked out an article. This article is from the January issue of Breastfeeding Medicine, and it's called Breastfeeding and Developmental Outcomes in Infants with Prenatal Cannabis Exposure, a retrospective cohort study. And the authors of this article are Nicole Knighty, Jennifer McAllister, Mishka Turplin, and Laura Kerr.
Cool.
Um, so this retrospective cohort study was designed to examine the relationship between breastfeeding and developmental outcomes among infants with prenatal cannabis exposure. And I picked this topic because I feel like cannabis usage is just exploding across the world, and there's more open um, talking about using it. And the authors referenced a study that found 77% of those who use cannabis initiated breastfeeding after delivery. And cannabis use during pregnancy is reported by 9.3% of pregnant individuals. So that's a lot of cannabis
I
usage.
know that's so much more than years ago. Plus, like, we don't even know what it means, right? Because cannabis is so variable with strength and duration of action and stuff like that. Yeah.
Right? So we don't know really what that means, how it's being used, meaning like the frequency of it, the method of being used, but it's out there. It's out
Yeah.
there, and we ought to know more about what the implications are of its usage. So, substantial research exists looking at prenatal exposure to cannabis and infant health outcomes, including the impacts on gestational age, birth weight, and infant neurodevelopment, but with mixed results. Um, and also, like we were all well aware of the substantial research that demonstrates that breastfeeding offers significant health benefits for mothers and infants. Um, and there has been shifts in attitudes towards cannabis usage and pregnancy and breastfeeding. For example, they updated in 2023, ABM updated their protocol number 21, breastfeeding in the setting of substance use disorder. Um, and that was a really great update that happened. In the end, it called for a shared decision-making approach, counseling against the use of cannabis during pregnancy and lactation, but cannabis is not a contraindication to breastfeeding. So there's we have this guidance from them, but to do educated shared decision making, you kind of need to know a little bit. And there's a lot of variability still in what advice people are receiving, and notably significant variability, especially when it comes to race and socioeconomic status.
Yeah, that's for sure. I mean, I think there's a lot of implicit bias. In fact, I know that I think we've talked about this, about evidence that people are racially profiled when they're counseled about cannabis during pregnancy. Women who are white, maybe middle-aged, no one talks to them about it. But if they're young and black, someone may say, "Oh, are you using cannabis?" And then counseling them. Yeah, absolutely.
Yeah. So, the objective of this retrospective cohort study was to examine the relationship between breastfeeding and developmental outcomes among infants with prenatal cannabis exposure. And I'm going to go a little more into this in the moment, just like um, tearing this apart a little bit. But so these babies were all exposed to cannabis prenatally, and then what they were, that was a consistent factor. The variable was the continuation of breastfeeding afterwards. So who was the population studied? The sample for this study, it was moms and babies who were born between 2013 and 2019, and they were drawn from the Maternal and Infant Data Hub. It's a perinatal data repository within a Cincinnati, Ohio academic hospital system. So this is actually really, really awesome, this Maternal and Infant Data Hub. It includes linked maternal and pediatric electronic medical records, their billing records, which could then give you diagnosis codes, maternal lab results from a universal drug testing during birth hospitalizations. And I'm not saying that universal drug testing should happen during birth hospitalizations, but
Right.
in
Yeah.
this community, they do it, and so we have that data. Did you want to say anything about
No,
universal
I was
drug
going to
testing?
say that, yeah, no, right. I mean, that's been something that is ACOG specifically said that screening does not necessarily involve biologic fluid to screen. Yeah.
Yeah. So again, not supporting that
Right.
practice, but it gives us this information. Um, And for the purpose of this study, prenatal cannabis exposure, it was defined as a positive maternal drug test at the time of the birth hospitalization. So it doesn't reflect the degree of usage during pregnancy. It was just a snapshot in time. That could have been like the one time that they did it, or it could have been multiple exposures throughout the pregnancy. And then the universal drug testing that they did, it also tested for other substances, including opioids, cocaine, amphetamine, benzodiazepam, and, and medications used to treat opioid use disorders like methadone and buprenorphine. So they identified a population of people who had positive drug testing for cannabis. The next part of the methodology, they looked at whether or not the babies who were born were breastfed. And this was based on breastfeeding at hospital discharge, which was a yes, no on birth certificate data. So again, another time where it was just a snapshot in time. It doesn't reflect the extent of breastfeeding that occurred after hospital discharge throughout infancy. So these could be babies who stopped receiving breast milk at a week. These could have been babies who continued to breastfeed for 2.5 years, and any and all in between.
But also, the decision to breastfeed at the time of discharge may have been, iatrogenic, right? If the staff said, "Oh, wait, you have blah 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 in your screen," then you can't breastfeed. So they leave not breastfeeding, but then maybe they go home. I mean, right? So there's that. And then and this, I may be jumping the gun, and maybe you're going to talk about this, but who was screened? Like, was there implicit bias in terms of who was screened?
Oh, good question. So, back to the universal drug testing, everybody was screened. So
Oh, okay.
everybody who went to the hospital had the drug testing done, but there definitely it seemed skewed who tested positive on it, at least based on the demographic data. I need to look, actually, I should go back to see the what the demographics of that area is comparison to the test here. So maybe I can actually, if you want to pull up Cincinnati, Ohio demographics, you could
Yeah,
you
I
can make
can
that
look it up while
comparison.
you're talking. Yeah.
Sure. Um, and then to what you were also saying, we don't know what happened after hospital discharge, like who maybe reinitiated after leaving the hospital, who weaned, and what their supports were there. Um, but I will go a little bit more to the demographics of who is included in the study in a little bit. Okay, so we got that yes, no, whether or not the babies were breastfeeding at the time of hospital discharge. The next step was the authors reviewed the infant's electronic medical record to check for diagnoses related to developmental delay. So, and they used various codes that they listed, but it was a pretty comprehensive list. And the infants who were born in 2013, they had up to 6 years of follow-up data, so a little bit more information. The infants who were born later were at shortest interval had 1 year of follow-up data. And then they used various statistical analyses to examine the demographic data they collected to compare the odds of developmental delay in the babies who were breastfed versus those who were not. And then they did various manipulations to adjust for potential confounders. So the babies were born preterm, their year of delivery, if there was other exposures to different substances like tobacco, opioids, cocaine, amphetamine, like everything that was also on that universal drug screening test. And then tobacco was just a question that they asked. And then they also
Then,
stratified the death. Sorry?
oh yeah, I was gonna, yeah, just ask you what other data they stratified. Yeah.
It was by birth year because the kids born in 2013, they just had more years of follow-up time. So they separated it by birth year too to see if they had to look further out for changes to be detected.
Yeah, no, I was wondering, like they probably adjusted for poverty for their income and race, because obviously kids who come from impoverished environments are going to have more difficulty with developmental delay.
Mhm.
Yeah.
So I didn't see that they stratified the data by that, but I did see that they looked to see between the two groups if there were statistical differences between the two groups.
I see. Okay. Assuming that other
Um,
all else is equal. I
correct.
see. Got it. Okay.
At least that's what I got from reading this.
Okay.
So who was studied exactly? They ended up capturing about 1,500 participants who delivered between 2013 and 2019. 67% were non-Hispanic Black, 30% were non-Hispanic white, 3% of birthing parents were of another race or ethnicity, and 94%, the majority of the participants had public insurance. And so I'm just curious, were you able to see what Cincinnati
Yeah.
data?
So it's not the same. So in Cincinnati, it's about 47 to 50% white, and Black population is 38 to 40%, with about 5% Hispanic and 2 to 3% Asian. So it sounds like there's a higher representation of people who identify as Black in your study. Yeah. In those who were found to be positive. Right.
Yes.
Yeah.
Yeah.
Mhm.
And then of these 1,500 and 20 participants who were included in the study, 54% of the infants were not breastfed and 46% were breastfed. And when you look at the demographic characteristics of participants by mode of feeding, looking at this, the statistical significance between the groups, it was maternal education, um, whether or not a baby was born early, was born less than 37 weeks, and the presence of other substances on the universal drug screening.
Interesting. Yeah, that makes sense.
Yeah. So, and the characteristics, I guess on the flip side, the characteristics associated with a greater likelihood of breastfeeding were Hispanic ethnicity, white race, college level education, having private insurance, the negative drug test for other substances, and being term.
hmm
So, the main outcome that was looked at was the odds of developmental delay between the two groups. Overall, 254 of the babies, or 17% of the infants, had a diagnosis code for delayed milestones or developmental delay.
Mhm.
In the unadjusted analysis, not breastfeeding was associated with increased odds of developmental delay. But after they adjusted for maternal tobacco smoking and other substance use, prematurity, the year the kids were born in, that effect, it lost its statistical significance.
Interesting.
Yeah, I thought that was really, really interesting. Um, but I want to talk more about that in a moment. When looking at the unadjusted data stratified by birth year to account for the potential differences in follow-up time, the effect estimates, they were similar except for 1 year. 2015, they noted was an outlier year, but the confidence interval for it, it still included the main analysis estimate. So it suggested no statistical meaningful difference. So the biggest limitation that I felt in the study that like had me wanting to know more information was we don't really know what breastfeeding means.
Right. Yeah.
So what actually ended up happening? What was the exposure to breast milk afterwards?
Yeah.
It was really limited, being based on just that delivery hospitalization as captured by the birth certificate data, and that's just a little checkbox from a very early snapshot in time. But it got me to think about like what outcomes we care about, and it maybe sounds super basic, but it felt like a light bulb went off in my head about like, oh, this is actually what you're looking at. Like breastfeeding as compared to formula feeding, could it decrease the odds of developmental delay?
Mhm.
Even will it not have any change in the odds of developmental delay, or could it increase the odds of developmental delay? Let's say usage was continued. Because that
Mhm.
was another thing that the study kind of missed was what habits were the parents continuing afterwards?
Yeah.
Like, were they going to use as an opportunity to, like, would there be a difference if the parents were continuing to use cannabis after a pregnancy where they were using cannabis, or maybe they used during pregnancy and then they were never going to use again in their entire life? And is there a difference between those two babies?
Right. Yeah. 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 It would be nice if the authors were able to explain like what kind of counseling these families got if they were, when positive. Like were they told, like were they entered into any sort of therapy, a behavioral, substance use clinic, something like that? How were they followed over time? Were they encouraged to breastfeed? We know that this population has a pretty low rate of breastfeeding because oftentimes they worry that they're poisoning their baby or they're told that they're bad parents and they shouldn't breastfeed. So yeah, but I agree with you. Just that one like check mark on this, on the birth certificate. You don't sometimes people, there's probably times that they just guess. I mean, I don't even, who knows how accurate those are. So I don't know. Um,
Yeah.
yeah.
And it also got me wondering more about the looking at the big difference between those who were breastfeeding at the time of hospital discharge and the discrepancies based on the level of maternal education and also the presence of other substances on the drug test. Like, was the decision to breastfeed or not breastfeed, was that being impacted by the cannabis use, or was it being impacted by the presence of other drugs
Right.
being detected too?
Yes. Right.
And
Yes.
um, those could be very different conversations.
Right. And also, I mean, there's going to be a lot of variability in terms of the hospitalist, right? To say, oh, you're using, pot or using cannabis or whatever, and they size them up and think, oh, this is probably a person who also is at risk for using other things. Maybe they find out that the partner has been using heroin. So they're like, no, no, you can't breastfeed versus, a middle-aged white woman who says, yeah, I just use it a little bit for pain. And then they're told, okay, it's fine, just try to limit how much you're using postpartum. So, you just don't know what's happening at the bedside and how they're counseled. So it's such
Right.
a it's a difficult study. And like you said, we have no idea how different these populations were postpartum in terms of breastfeeding. So, but
Yeah.
it's a good start. It's a good thing to talk about, right? But when we look at like the ACOG statement that was recently updated, I think I podcasted on that or did a lack fact on that, regarding their most recent recommendations on cannabis use during pregnancy and lactation. Whenever you read about this, there's always a statement like, "Oh, this is bad for the baby's development," and there seems to be some evidence. I don't know how much of it is more animal. I just haven't done a deep dive into, all the specifics on that, but clearly people think that it's not good for babies' development to be exposed.
Yes. And I will say that the authors did put very clearly into their discussion that the results of the study should not be interpreted as a complete assessment of the safety of cannabis exposure through breast milk.
Yeah, yeah.
So that
That's,
is definitely a big takeaway to take, that these uh we can't make those generalizations about safety yet.
yeah, yeah. And it's such a tricky topic to be studying, right? Because you don't know if you're looking at outcomes, like you don't know, was it that critical time period that the baby was exposed to THC during gestation, right? During fetal development, or was it the amount that they were exposed to during lactation? And so you just like, where's that critical? We know that there's like critical time periods. Like we know that infants that very young infants who are exposed to a lot of fructose during lactation have actually there's some brain impacts on that, versus being exposed to fructose at other times, even if they drink fruit juice, after 6 months of age. So there are these critical time periods of development, particularly for the brain. We just don't, yeah. So it's tricky to study.
Mm-hmm.
Yeah, yeah. So it almost seems like more of a thought experiment and more of a conversation about how tough this is to study versus like looking at the actual outcomes of that article that you presented.
Yes.
Yeah.
Yeah. It also got me wondering when you're collecting information, how you can ask people to be very transparent with giving you information and saying, like, we're collecting this to learn information, not to impact the care or the, like, how I'm going to treat you.
Hmm.
Um, and I wonder also, like, the limitations in getting data, like, how open people are about their usage if they feel like the person who is collecting the information, if that's going to somehow get back to how
Right.
they receive care.
Yeah, absolutely. Yeah. Yeah, it's kind of the difference between like when you do a retrospective cohort study like this is where you look back, there's so many questions and you don't have the follow-up and you don't have all the information you need, so you get these limited results. But then if you do a prospective cohort study where you're following people over time, number one, they're going to be nurtured a bit. So it's not going to, that population is not going to reflect the general population who may be using, right, substances. And so, yeah, it's hard to get a snapshot for sure, really, of like, what's happening in the wild, basically. So, yeah,
Yes, the wild home environments.
exactly. Yeah. All right. Well, let's go on. Thanks for bringing that up. I want to talk about the most recent Academy of Breastfeeding Medicine protocol that was published in Breastfeeding Medicine Journal in November of 2025. And this is protocol number 7. So it's one of the earliest protocols that was just updated in 2025, called the Model Maternity Policy Supportive of Breastfeeding. So the last version was in 2018. The authors of this protocol, they explain that the reason to have this protocol is to help maternity facilities comply with the requirements of baby-friendly hospital initiative implementation guidance. So in other words, hospitals, they want to be baby friendly, they want to implement the steps, and they're looking for policies and trying to, put these things together. And rather than reinventing the wheel, these authors put together this model policy, which they recognize as like, it's a foundation and it may need to be changed depending on the country, the region, the culture, et cetera. But it's a really great start and a great framework. And I really want to emphasize that. So the update for this protocol is based on recent World Health Organization and UNICEF publications on perinatal care for mothers and infants. And they also include information on prematurity as well. So it's really just
Mm.
looking at the last one, 2018, saying, okay, what's new? Let's update this policy. And so I want to go through just like some of the specific updates rather than going through the policy from start to finish, because it's a pretty long policy.
Yes.
So one specific update is that they no longer recommend breast massage for mastitis, which of course we know can
Yay.
aggravate local inflammation and create more complications such as abscesses. So that's great. And then, but they do mention that gentle breast compressions during pumping can help with milk removal. So for those who are exclusively pumping. And then they
Mhm.
talked about there's a fair amount of conversation in this protocol about bottles in preterm infants and pacifiers. And so there's stronger evidence about not using bottles for preterm infants and allowing, but yet it is fine to, or it's reasonable to use pacifiers for preterm infants when the mother is not available. And then they talk about some newer evidence, some about cup feeding and syringe feeding being preferable to bottle feeding, and also supplementation at the breast being preferable to bottle feeding in terms of the impact on leaving the hospital breastfeeding and the duration of breastfeeding. Um, they then talk about the updates on HIV and breastfeeding because obviously in the US, those recommendations have switched from don't breastfeed if you're HIV positive to shared decision making and supporting a mother's decision to breastfeed when the mother has undetectable viral loads and she's remaining on suppressive therapy along with consistent follow-up. They have a paragraph about the importance of chosen pronouns for transgender and non-binary parents, and then also chosen terms for infant feeding and for breast milk. This new version acknowledges feeding at the chest after top surgery or gender affirming surgery. And they also just briefly mentioned that just acknowledging basically that people do induce lactation, particularly cisgender females, when there's co-lactation happening, transgender females, or people with other gender identities. Uh,
That
the,
is great because like did they touch upon in it with like bringing milk to the hospital if you don't have like if the parent isn't producing milk directly but they're bringing milk that they already have? Did they address
yeah,
that at all?
you know what, I don't recall that they do. So they don't get directly, too much into the weeds in that regard. They might though. Yeah, I'm not sure, but certainly, there's evidence for that, for even antenatal custom expression too. Um, the new protocol also addresses the use of different strategies for learning, which I thought was interesting, making sure that there are interpreters for different languages so that we're not relying on like family members or kids to speak to people who have different languages. And then also when educating patients to use different types of modalities for learning, like not just giving them a handout or talking to them, but actually showing images, videos, and then tactile materials like having a doll or having like a cloth breast where they can actually demonstrate these things for people because learning is enhanced by doing that. Um, they do mention the importance of healthcare professionals identifying their implicit biases through self-reflection, listening, and continual education so that there's an equitable and respectful environment for patients and also for healthcare workers. Um, so they do have a paragraph about the importance of breastfeeding, and I think that me, like all of us in breastfeeding medicine, we say, yeah, breastfeeding, getting off to a great start postpartum because of these enormous health benefits for birth parents and newborns. But I really like the way that they frame the importance of breastfeeding. Um, and so they describe that the mother's breast is the natural habitat for newborns and infants, and non-initiation or early cessation of breastfeeding poses significant risks to maternal and infant health, as well as significant social and environmental costs worldwide. And so this just feels like a much stronger statement on normalizing breastfeeding. And I think it was just really beautifully written. And so we need to do, we need to be more eloquent and more assertive about normalizing rather than because whenever we talk about, oh yeah, getting off to a great start, all these health benefits, it still sounds like icing on the cake. It still sounds like, and if you have this salad with your dinner, you will have this benefit too. You get more roughage, something like that. Like we have to stop talking in that way and not speaking in that way. They emphasize in the importance of breastfeeding that the first 2 years of life are critical for the development and growth of most organs and systems, and also for the acquisition of social and affective behaviors, and then also the development of the immune system, right? So it's critically important for immune system development for the infant. And then breastfeeding is like just, it's comfort, it's peace, it's love, it's warmth, it's bonding, it's security for the baby. So it's really that best environment for development and growth. There was an article that I have, I don't know if I ever shared it on a podcast. It's called The Developmental Nest. And it talks about like how babies being skin to skin, like this is really their nest, just like, other animals have nests, right? Well, human babies, their nest is right, like skin to skin. And it talks about the fact that it helps to having the baby skin to skin on a regular basis really develops that vagal nerve, so that babies in that fight or flight reaction, it sort of tones it down a bit so that they're not constant, so they feel less anxious. And so I just want to bring that up because there is evidence, like there's biologic evidence for skin to skin and how it can really help to program that neural system.
That's so interesting.
Yeah, it's really, and I have to share the article with you. Yeah, it's really cool.
Yeah.
So yeah. So the other thing is that they do have a couple paragraphs on the evidence for baby-friendly hospital initiative, which I think is important because I think there are more and more hospitals who are choosing to not be baby friendly because of the onerous sort of steps and criteria that are needed to kind of keep it updated. And it's also
Yeah.
expensive. But, Baby Friendly Hospital Initiative is a quality improvement initiative. And there's evidence that it works much better as a bundle than implementing just a few steps in terms of its effect on breastfeeding rates. And that organizations tend to,
Accountability.
what is that? And accountability. Yes, and exactly right. And that's the other thing I was going to mention is that organizations perform better in terms of abiding by the steps if they are accountable to an outside body. And also if they work collaboratively. So we see like with CHAMPS and I don't know if you know, well, Dr. Bobby Phillips from Boston Medical Center, she spent a great deal of time a number of years ago, I think before the pandemic, bringing hospital systems together in different states. She was sponsored by Kellogg to go to different states to do these collaborative meetings with different hospitals to really encourage them to uptake the implementation of baby friendly. And so when hospitals work together to do this, they can be more successful because they can share resources, ideas, and write policies together.
Hmm.
The protocol, this policy also cites the evidence on the effect of not abiding by the code of marketing on breastfeeding rates. So when hospitals don't abide by the code of marketing, their breastfeeding rates are affected. And they also cite studies that demonstrate how healthcare providers themselves who have conflicts of interest by accepting gifts such as food or free conferences or education, they actually provide less breastfeeding support. So those formula companies, they know how to market and they know how to change the minds of healthcare professionals. So it's pretty scary. It's kind of like you can get a little brainwashed if you spend some time, getting free cheesecake at a conference. Um, or at a seminar, that you get invited to with a fancy steak and potato meal. Uh,
Yes, really, there is no such thing as a free lunch.
there you go. Yes, it's really true. Yes. Um, so the policy has a section on addressing uh, support for breastfeeding and breast milk for preterm, low birth weight, and ill neonates. And so they do emphasize that receiving mother's own milk in the NICU is really important in reducing morbidity, mortality, and also to optimize neurobehavioral development. Like these babies have superior neurobehavioral development and higher
Mhm.
exclusive breastfeeding rates at discharge, in addition to longer breastfeeding rates after they leave the hospital. And they do have a statement that says that the use of mother's own milk is superior to pasteurized donor human milk, although they also say that donor human milk is superior over preterm formula, especially when it comes to bronchopulmonary dysplasia and necrotizing enterocolitis. They also really encourage oral colostrum care or oral immune care. So giving that colostrum early to infants in the NICU to reduce the risk of necrotizing enterocolitis, late onset sepsis, and neonatal death. So really important early on. They have a really great section on kangaroo care, which is defined by the World Health Organization as continual and prolonged skin-to-skin care, ideally 24 hours a day. And the protocol says, I'm sorry, but the World Health Organization says a minimum of 8 hours a day, ideally 24 hours a day, but 8 hours a day minimum. And they have a really nice summary on the evidence of benefits of kangaroo mother care. So this is, I think, um, one of the strongest qualities of this protocol is that it so succinctly summarizes evidence for people. Like if they're trying to come up with a policy in their hospital to improve skin to skin care or to stop using nipple shields or whatever, they can go to this policy and say, okay, what are the references that they used? So really just super, it's really a gold mine, for people who are trying to write policies at their hospitals.
Or
I
I'm
just,
thinking about what you just referred to with the kangaroo care, even changing visitations to come to see a baby in the NICU
yeah,
to not have limited hours.
right.
Refer to this policy, change the visiting hours for your NICU so parents could see their babies more frequently.
Exactly. Yeah. 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 I don't know. I mean, I don't think our NICU has, I mean, I don't know how many NICUs are still doing that, limiting hours. I don't know. But also like understanding like the importance of other people doing skin to skin, right? Like it can be, someone needs to be there. I mean, I can't imagine leaving my child, obviously people they need to go back to work and things like that. But if you have the ability to be with your child all the time, it's kind of like if it's almost like we see it differently. I've had a kid who was really sick who was hospitalized. We never, ever, ever let our child, he was there in for a month in the hospital. We never let him be there without a parent or a relative. He was never alone. And
Mhm.
and I think in my guess in other countries where there aren't as many staff available, right? That the family oftentimes are responsible for like feeding and changing and doing all the things. Um,
Yeah, I
so
guess I was thinking about we had on one of our events, someone was presenting about breastfeeding in a NICU setting. I think they may have been based out of Puerto Rico, and their NICU had limited visiting hours.
yeah, I'm sure it probably happens. Yeah. I don't know how much it would happen here because I think that it would probably, I don't even know if they could sue the hospital really for that because it's their child, right? Um, so
Yeah.
yeah. Yeah, but I just want to say, I just want to thank the authors for this work. This is a really great protocol. And it takes, I know what it's like to write a protocol, to be involved in one, and it takes a lot of time, a lot of expertise, and they do it for free. So kudos to them, and they should be proud of it, to this protocol.
Yes, thank you. And I want to say I love the table six that the authors put in there where it's the list of essential issues that every breastfeeding mother and family should know to be verified with mother before discharge. That
Uh,
is
yeah, that's
such
golden.
a
Yeah.
nice comprehensive table. Um, and I feel like so many people I see in the outpatient setting like would not be able to recite back this list to me. And if they could, it would be game changers for these families.
Yeah, 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 absolutely. Yeah, no, there's so much here. Like I started looking at this thinking like, okay, how am I ever going to get through this protocol in our podcast? So I just kind of went over the highlights, but yes, that table is amazing. And again, for a unit that's just starting out, who just really want to kind of change things up and optimize their support, like how amazing it is to have that checklist. So
Thank
yeah,
you, authors. You guys are awesome.
yeah, yeah. All right, Lena, well, that's a wrap. So I'll talk to you in a few weeks.
See you then. Bye,
Yeah.
Ann.
Bye. Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org. So come check us out and become a member to join our community.